entitled Rehabilitation Approach to Charcot Arthropathy of the Foot and Ankle.
Thank you, Fazrin. Assalamualaikum and good morning to everyone. I think it's not too late for me to wish you Selamat Hari Raya. This would be the last CME for the Shawwal month, okay? I know a lot of you have other places to be. There's a lot of Jamuan Raya going on, so I'll try to make this as short as possible. I can see there's also something going on after this, okay? So we'll try to finish in time. Okay, so my topic is a bit of a handful. It's called Rehabilitation Approach to Charcot Arthropathy of the Foot and Ankle. Maybe some of you do not know what is Charcot Arthropathy, but most probably you would have seen it at least once. Okay, it's quite common, but it's grossly underdiagnosed and commonly misdiagnosed. Before I proceed, can the other people at the old hospital see the slides? No? Okay. Alright, so Charcot has a lot of names. It's also known as Charcot Arthropathy, Charcot Neuroarthropathy, Diabetic Neuropathic Osteoarthropathy, Neuropathic Arthropathy, Charcot Foot and Ankle being the most common lah. Okay, so but it all means the same thing. So what is it actually? It's a progressive and painless, being the keyword, condition characterized by acute fractures, dislocations and joint destruction in the weight-bearing neuropathic foot. If it happens in other joints, then it's called knee or spine, okay? Alright, but this is when, because we're talking about Charcot foot, so it's dislocation and joint destruction of the foot. Okay, commonly it will affect the foot and ankle joint, but it can also affect any other joint, okay, like the knee joint. Okay, we've seen a few, one or two cases. The prevalence is about less than 1% to 13%. Okay, it doesn't seem like a lot, but it's actually largely underdiagnosed or misdiagnosed. So we're actually missing out on a lot of diagnosis of Charcot. It was first described maybe about 300 years ago. Is it? So Sir William Musgrave, a physician, actually described neuropathic arthritis with syphilis being the cause. So at that time, the most common cause for Charcot foot was syphilis. Okay, then an American physician actually noticed in patients with TB spine, okay, because they have TB spine, they have lower limb weakness, insensate foot. So he noticed hot, swollen, and asymmetrical joints. It was Jean-Martin Charcot, a French neurologist, who actually coined the disease like the disease was named after him. He recognized the previous findings, okay, and he described it as a continuous denervation-induced degeneration of the foot and ankle. Okay, leave it to the neurologist to get a name for all the diseases that someone else has described before. Huh? Okay, so this is how your Charcot foot looks like. Can you think of anything else that looks like this? Cellulitis, alright, I think that's one of the most common diagnoses people would give. Some acute gout attack, okay, if you see the initial picture, okay. Some people will also diagnose as DVT, any form of arthritis. Okay, at the initial stage, when patients present with this, it's quite difficult for us to diagnose Charcot if we don't have it at the back of our mind, okay. But once the swelling resolve, okay, then you see this deformity. At this time confirm lah, memang Charcot foot. Okay, senang lah at this time for you have to say, alah, this is Charcot. Okay, kenapa mula-mula tak cakap dulu? Because when they present initially, it's just a swelling, unilateral lower limb swelling, might be painless, okay. So it's quite difficult to diagnose. So this is an example of a patient with Charcot knee. Okay, it's not so common, okay, but this patient actually presented with knee swelling. Okay, X-ray done, not so much changes, so they just treated as osteoarthritis. 6 months later, okay, patient presented for routine foot examination, and somehow patient say, actually I haven't been able to walk for the past 6 months. And then kita buat exam belah knee. Alright, and notice there's a huge swelling over the right knee. When we did X-ray, totally dislocated. Okay, the knee. Alright, so it's a Charcot knee. Not so common, but it can happen also. So previously, back in the old days, okay, the main cause of Charcot foot is syphilis, because it wasn't so treatable back then. Okay, now the main cause will be diabetes. Okay, actually anything that causes peripheral neuropathy, insensate foot, loss of protective sensation can cause Charcot joint. Okay, but the commoners that we see day in and day out would be diabetic. You can have syringomyelia, polio, congenital neuropathy, any traumatic injury, leprosy, and some toxic exposure. How does it occur? Well, as I mentioned before, it is due to neuropathy. But which type? People haven't been able to actually pinpoint what is the exact pathophysiology or cause of this neuropathy, but it's probably a combination of all the different pathways. So they have neurovascular theory. Okay, patient with long-standing diabetes will have some autonomic dysfunction. They can have hyperemic state due to increased blood flow. So this hyperemic state can actually increase the osteoclastic activity. And then there's a neurotraumatic theory, whereby patient has loss of protective sensation. So they keep on walking and they don't recognize that they have trauma. The sidong sikit ke, trip ke. Okay, for us probably be painful, but for them it's quite painless or minimally painful. Okay, so they keep on walking even with the fractures, micro fractures. So that can lead to further deformity and also local inflammation. And then there's also excessive local inflammatory response. They noted that patients with diabetes can have this increased pro-inflammatory marker, your rankle, your TNF. Okay, so those cytokines can induce more inflammation, can cause more bone resorption. And diabetic patients are also prone to non-enzymatic collagen glycylation, especially at the tendon Achilles. So when you have the glycylation, your tendon Achilles will be shortened. So you will walk a bit like plantar flex, tiptoe. So the pressure exerted on your forefoot will be great. For us, we walk mainly with our heel. So that's the normal place. We have your heel pad. Okay, that's good pressure absorber. But here at the metatarsal region, it's not so good. So when you keep on exerting pressure on the forefoot area, you will get abnormal pressure and can cause ulcer and also microfracture. Genetic predisposition is something that they have been looking into. So far, we don't really have a definitive answer yet. But in conclusion, all of this might cause Charcot foot. Okay, so this is a very simple diagram. Okay, it doesn't really explain everything, but I think it's enough for us to understand. Okay, any patient with neuropathy or long-standing diabetes, okay, they have insensate foot, loss of protective sensation, okay, that can cause micro-trauma. Okay, and there's also some local inflammation or infection, which can cause deformity and also ligamentous laxity. So when patient walk, because they are not in pain, they continue walking, so will cause further degeneration of the joint and also all the other bones lah. So all this deformity can lead to ulcers, okay, or Charcot foot deformity, okay, leading to abnormal pressure, causing further ulcer lah. So it's a vicious cycle. Okay, this is another busy diagram that shows how these theories actually interplay with each other. Okay, but I think it's enough for us to know that loss of protective cells in patients with neuropathy, especially diabetes, will cause patient to have Charcot foot. Okay, through inflammation, through increased osteoclastic activity. Okay, so why is it so difficult to diagnose? Like I mentioned just now in the earlier picture, when you see the first unilateral foot swelling, probably you would think of something else. you probably think of cellulitis, DVT, some form of abscess, acute gout. Okay, we've seen patient who has been referred saying that acute gout not responding to treatment. Okay, some form of inflammatory arthritis. And the thing is, it's not making things easier for us to diagnose because initial X-ray may be normal. Okay, patient may be painless, okay, or minimally painful, and they usually do not recognize any precipitating event like a trauma. There is also lack of systemic symptoms, which can actually guide us in maybe ruling out like cellulitis or something. Dia tak ada fever, no loss of appetite, no loss of weight. Unremarkable lab findings. Total white is not so raised lah. Kalau raised pun sikit. And then inflammatory markers also not so high. Okay, compared to if it was an underlying infection like osteomyelitis or cellulitis. So, because it's so difficult to diagnose, there's a study that shows there's an average delay of at least 29 weeks between the occurrence of the first symptom and diagnosis. So that is a long time. That's almost 7 months. Okay, so that's why we need to diagnose it early so that we can give treatment. Okay, so we as healthcare professionals should consider diagnosis of acute Charcot foot in any diabetic patient that we see who presented with unilateral swelling of the lower extremity. So far it's clear, right? Okay, so how do we classify? We can classify it clinically, anatomically, or by the natural history. Okay, so in clinical classification, in acute setting, you have that really angry looking swollen foot. It's red, it's warm, okay, swollen. Usually it will start with the midfoot, okay, and then you can spread up to the shin. Patient is not complaining of any pain. Okay, no obvious deformity at that time yet except for the swollen foot. X-ray may be normal or you may see some fragmentation or microfractures. Okay, our aim at this time to arrest further disease progress and to avoid further bony destruction to the foot. Okay, because it's very difficult for us when there's deformity. Then you have your post-acute to chronic stage, okay, whereby your signs of local inflammation will slowly start to resolve. Okay, so your swelling can be reduced, the warmth can be reduced, okay? But it depends lah, the acute stage, if you keep on weight bearing, keep on walking, you will cause further inflammation, then your acute phase will be very long and can last up to 10 months. Okay, but if you can get it under control within 2 to 3 months, okay, then we can proceed to the chronic stage. Okay, at that time there may be or there may not be any deformity. There's midfoot plantar arch collapse with rocker bottom deformity. Okay, there's medial convexity because of the medial arch collapse, so there's prominent medial aspect of the midfoot. So these deformities will result in abnormally high pressure areas. Yang selalunya tak ada pressure, now you put pressure, so they are prone to ulceration. So at this point, our aim is for therapeutic footwear and to prevent further complications that can lead to morbidity like amputation or mortality. Okay, there's also classification by anatomical, Sanders and Fragment, Brodsky, but for us it's not really important for rehab, maybe it's for our orthopedic colleagues because they need to know at which level is the Charcot Arthropathy at. Okay, so your metatarsal and then your subtalar. So natural history is important for us. Okay, so we use the modified Appendix classification, which is a radiological classification plus the clinical findings. So you have your prodromal stage and your reconstruction stage. So at every stage of the disease, our treatment will be different. So your prodromal is when you have your initial symptoms but normal X-ray, and then it will develop into your fragmentation, where you have your fractures, and then after that, as the inflammation slowly resolve, it will become the coalescent stage where it starts to absorb the debris, becomes sclerosed on X-ray, and then reconstruction, you have the consolidation of that joint, it will become deformed. Okay, at different stage, we have different rehab intervention. So what is the management for Charcot foot? It's simple, but it's very difficult to do. So what you need to do is offload and offload. That is the most important thing. So when you see a patient with this, in the back of your mind, okay, maybe you treat as cellulitis, but you still have to think about Charcot. So you still need to advise patient on non-weight bearing or immobilization. Okay, so that it won't progress, because next you will give TCA to the patient to see either orthopedic or rehab, right? But during that time, 1 week, 2 weeks, they can have further destruction of the joint. So you need to immobilize it. So gold standard is total contact casting. It's your normal POP cast. So any place can do, right? The place that has POP. Okay, we don't do it at our clinic. We send patient for TCC at other department lah. Okay, so what it does, it evenly distributes forces across the plantar surface of the foot. Okay, we have to change it quite frequently, so we give quite regular TCA, because once you start doing TCC, the swelling will dramatically reduce. So it will become loose, so you need to apply another TCC. Patient may be allowed guided ambulation, okay, with crutches, but usually we don't advise lah, because they're not so compliant on non-weight bearing ambulation. About a quarter of those who actually are treated with TCC did not develop deformity, so that's why we try to advise patient to get TCC as their initial management lah. Okay, even if they have ulcer, it can help in management of the ulcer, because when you don't apply pressure on the plantar surface where the ulcer is at, you can promote healing. So we try to advise patient to go for TCC, but it's quite difficult. One, because patient is ambulating, and two, is painless. So you will actually severely limit patient's ability to walk. But it's quite necessary, yeah. So usually they will opt for this lah, some removable immobility walker, like the pneumatic walker. It's prefabricated. Okay, what it does, it decreases forefoot and midfoot plantar pressure. Easier for us to do wound surveillance, because in TCC probably we need to do a cut out to see, or we need to remove the cast to monitor the wound. But here we can just remove the walker and ease of application. You would think that patient will have better compliance with this, but no, patient will actually be more non-compliant, because they can just remove it anytime they want. I can show you later of a case report that we have. So for pharmacotherapy role at the acute stage, there have been some studies that look into medications. More often than not, it's anti-resorptive agents such as bisphosphonate, calcitonin, and denosumab, because theoretically these agents will reduce the osteoclastic activity, but the result has been mixed, so we don't really institute this treatment lah. Yeah, but just nice to know, or probably somebody wants to do further study on this. Okay, long-term management, we want to prevent structural deformities and complication by optimizing diabetic control. This is so important for us, because continuation of hyperglycemia will cause further injury and will impair wound healing. Okay, so we need to optimize the diabetes control. Okay, our physiotherapy colleagues can help with strengthening exercises, gait training, and endurance exercises once patient is allowed to weight bear. For our occupational therapy colleagues, they can help with modification to their activity of daily living, because probably we need to advise them not to walk so much lah, so we need to use wheelchair. So their activity of daily living has to be at seated level. Okay, so we also prescribe therapeutic footwear and surgery referral to our orthopedic colleagues if needed. The aim is to create stable, painless, and plantigrade foot. Okay, they have different type of surgery for different condition and different aim. It can be arthrodesis, exoscectomy, okay, or if need be, then they need to do amputation. Okay, so these are the therapeutic shoe wear that we mentioned. It's not just your regular shoes. Okay, we usually give this for patients with minimal deformity of the Charcot foot. Okay, not so much like flail, ankle. Okay, this one is quite stable, so we prescribe with either diabetic shoes or customized shoes. Usually they will have extra depth to accommodate for the deformity, because patient with diabetes may have clogged toes. So if you have your normal tight shoes, it will rub against the shoe, causing more harm. Okay, so we need extra depth and then extra width shoes. And then patient will also be prescribed with customized insole to give even distribution to the to the foot. Okay. Patient with loss of protective sensation may complain of feeling the shoes too large, even though the shoes are actually properly fitted. Because of the loss of protective sense, dia tak boleh rasa. So dia kata ini besar sangat, padahal it's actually ngam-ngam lah. Kalau ketat sangat, they feel better, but actually it's not good for them. Okay, so it's quite difficult for us to counsel for compliance as well. This is how you do your total contact insole. You have your foam box, you wet your cast, and then you make the customized insole lah. Okay. We also have our crow boot, okay, Charcot restrained orthotic walker made out of a plastic. It has padding inside and it has Velcro straps with rocker bottom outersole to promote easier progression of the foot when patient is ambulating. It reduces plantar pressure and also protects the foot from the environment. Something similar to crow is your patella tendon bearing ankle foot orthosis. Okay, it reduces axial loads on the distal part of the leg, which is your ankle and your foot, while walking. Okay, it can transfer the weight from the ankle to the AFO by 30 to 100% depending on the fitting. Okay, if they make it nicely fitted, then you can actually transfer the whole weight to the AFO. So the weight is borne by the circumferential containment of the AFO as well as the restriction in ankle motion. For us, it's custom made, but there is some prefabricated one. So this is a knee ankle foot orthosis for patient just now who had Charcot knee. Okay, so the knee is unstable, so we actually prescribe with this orthosis, knee ankle foot orthosis for therapeutic ambulation. Complication of Charcot foot, I already mentioned just now, the foot and ankle will be deformed. When ulcer happens, it's very difficult for us to treat. When ulcer happens, they will have recurrent ulcers and they will need foot surgeries such as drainage or wound debridement or any limb salvage surgeries. Okay, if that fail, they might need to be amputated. So bear in mind, almost half of the patient with ulcers will need to be amputated along the line. Okay, so we really need to prevent the ulcer from happening by preventing the deformity of the Charcot arthropathy. It will increase morbidity once patient has to be amputated, increases mortality. 5-year mortality can be about 30% and reduces overall quality of life. Patient is unable to walk, will have limited driving capabilities and have to prematurely retire from their jobs. Okay, so once the ulcer happens, ongoing Charcot, patient will be on long MC. It's quite a loss to our economic ability, and most of them are quite young. So now we move on to the last part. Okay, I think I'm really in time. Okay, so 46-year-old gentleman with long-standing diabetes is actually a healthcare professional. Okay, so underlying diabetes for 12 years, but now compliant to the OHA for 2 years. We referred from health clinic to the emergency department, complained of foot swelling for 2 weeks. Okay, initially started at the dorsal aspect of the foot. So remember just now I mentioned it will start usually at the metatarsal region, midfoot. Okay, and then it will progressively get swollen up to the whole foot. Okay, so because the foot was swollen, he still wore his shoes and developed blister at the medial aspect lah. Okay, but he had no fever, no systemic symptoms. Okay, the treating doctor was quite good in eliminating all other possible causes of unilateral leg swelling, DVT, darul out, semua afebrile, not septic looking. Okay, so they did X-ray, think that it's osteomyelitic changes because patient had ulcer and then got some some changes over the X-ray, so they might think it's osteomyelitis. Counsel for surgery, of course lah, patient tak nak kan, patient can walk, then suddenly you counsel for surgery, memang tak nak lah. Okay, so tapi they agree for antibiotic use. Okay, so they treat with antibiotic, okay, given TCA. So this was the initial X-ray. You don't see much, but actually you can notice there's some fragmentation over the metatarsal region, okay, and also over the third metatarsal lah. Very subtle lah kalau yang tak biasa tengok. Alright. So 1 week later at the specialist clinic, the left leg was still swollen okay, that the wound has already healed. Now noted flat foot. See how fast the progression is, okay? No fever, nothing lah. Because why? Patient was not in pain and still ambulating without any walking aid. Okay, so continue lah dia punya inflammatory and all the fractures. Okay, so at that time already gave the impression of Charcot foot, referred for foot modification and suitable footwear to occupational therapy. Actually, occupational therapy they don't do acute management for the Charcot foot. Okay, please refer to rehab lah. Okay, or if you can refer for TCC. And the orthopedic also is quite good before the TCA. Okay, we need to immobilize the joint. Okay, at this point you can see more clearly, right? Is it more clearly here? Okay, I can see it in my laptop, but you can see the fragmentation is there. Okay, there's some fractures. Overall, memang doesn't look normal lah kan? Alright. So 2 days later, our occupational therapist colleague actually referred to us lah because they got the referral. So we saw the patient. Okay, memang sugar sky high, 20, dia punya DXT ya. Left leg was still swollen because patient was walking. Okay, dah ada rocker bottom deformity. At this point, patient has been walking painlessly for about 3-4 weeks and we counsel for total contact casting. Tak nak punya. Okay, of course they won't want to be restricted by the total contact. So it's probably easier for you to counsel them early on. Okay, but he is agreeable for removable pneumatic walker with no non-weight bearing ambulation. But it's removable. How compliant can you be? So 1 month later, we keep on seeing serially with X-ray. Okay, now the swelling has much reduced, but you can see other deformities lah. When I mentioned just now about the collapse of the medial arch, which is actually obscured by this. Okay, you can see the flat foot already. Compared to this side, nampak tak ada arch sikit. Okay, this side is totally flat. Okay, and now dah ada ulcer. Why? Because patient complain malam-malam dia nak kencing. Takkan nak pakai pneumatic walker pergi toilet. So keep on walking. So develop ulcer. So that's why we don't really encourage pneumatic walker lah. But kalau memang betul-betul tak nak TCC, have to. Alright. So we have to manage the ulcer now, which is another problem. Okay, so now at about 6 weeks post event, patient we can notice there's some sclerosis, there's start some absorption of the debris. The deformity is still there, but does start coalescing. So kalau icon halts, it's about stage 2 already. Okay, at this point we need to think about continuing the immobilization and also therapeutic footwear. So we have to give temporary offloading insole, which we fabricate ourselves. It's temporary, so we add Lunamed with Pilite, okay, to offload the pressure at the ulcer area. Okay, bandage the foot, okay, and put it inside the pneumatic walker lah. Hopefully the ulcer can be healed. Patient is still undergoing treatment, so we do not know the end result yet lah. Hopefully we can salvage the limb. Okay, so I think this is my last slide. The most important take-home message for this CME is that we need to educate patients, okay, and on the signs and symptoms, and also our frontliners need to know about the disease process of Charcot foot and the urgency of early diagnosis. Okay, we need to have high level of suspicion in any diabetic patient with peripheral neuropathy who present to us with unilateral leg swelling, with or without trauma or pain. Okay, it's very important. Once you have recognized that it's probably Charcot, or even if you think that it's cellulitis but might be Charcot, try to offload it. Okay, counsel for TCC, like your plaster of Paris, okay, and try to immobilize. Kalau dia tak nak pun, ask to use wheelchair lah, or non-weight bearing ambulation with crutches. Okay, our aim is to maintain a stable plantigrade foot that remains free of ulceration and infection, because we want to prevent complication which can lead to amputation and also cause mortality once the ulcer is infected. Okay, I hope that this CME has actually created awareness amongst our healthcare staff on the importance of diagnosing Charcot foot. So these are the reference that I got that are not presented in the previous slides. I would be happy to answer any questions that you might have.